Good afternoon, friends, and welcome to this important session. And I really congratulate Dr. Rajiv and his team for keeping this topic. He rightly said that most of us are interested in the adult foot surgery, but yes, this is another important topic, and we need to know. The Ponseti treatment has really made a significant difference in the life of many children. And I just would like to say that this Dr. Ignacio Ponseti was working as a pediatric orthopedic surgeon at Iowa. He expired in 2009 at the age of 92. A very important person. And the problem is that, the message which I would like to give over and above the Ponseti technique is that he published his result in 1963 in JBJS. That was his first paper on the Ponseti technique. No one really paid any attention to that. Then in 1980, he had a second paper again in JBJS about the Ponseti technique. World did not pay any attention, and we continued to have a debate in all the orthopedic conferences about which surgery to do, which approach to take. At last, in 1995, he published a paper with a long-term follow-up which showed that at 30-35 years, the results of Ponseti techniques are really great. And at that point, world realized that, yes, this is something we need to do. And then people started paying attention to that. This is the book which appeared in or published in 1996, Congenital Clubfoot. And I recommend every postgraduate to read about this. This is his lifetime contribution. So let's come to the principles of Ponseti technique. There are two phases of Ponseti technique. The first one is like the correction phase, in which we correct the deformity. And the second phase is the maintenance phase, in which the deformity which we have corrected, we try to maintain it so that it does not relapse. So these are the two phases, and we are going to see about both. So let's understand the first about the correction phase. How do we correct it? So for that, a simple question which I ask every time, what are the deformities of the clubfoot? And various teachers, various books, they explained differently. But for the Ponseti technique, I would suggest that we need to remember that there are four components of the deformity. Of that, first is cavus. So what is cavus and how it is different from a plantaris deformity, that we are going to understand. Cavus is basically a plantar flexion of the medial ray or the first ray. To explain this point, I'm going to show you an animation. We are looking, this picture is trying to show a hind foot, and this is a right side hind foot. We can see that the yellow plane, yellow line which is showing the plane of the hind foot, and medial and lateral side are shown. That shows that hind foot is in Varus because the medial side is up. Now in clubfoot, the first ray is more plantar flex than the fifth. If you look at a plane or if you join a plane, the first metatarsal and the fifth metatarsal, you will see that the forefoot is pronated in relation with the hind foot. This is a very important concept which Ponseti told us. And this is very important when we are trying to correct the cavus. How we need to correct cavus, that we will see later on. So cavus is basically a forefoot pronation. And if we want to correct cavus, then we need to supinate the forefoot. Coming to the second deformity, that's a forefoot adduction. So what we understand by forefoot adduction, let us see this picture. This is a long axis of the talus. This is actually a model the dissection which Dr. Ponseti carried out, and he shared this picture with me. So this black line is the long axis of talus. We can see that the forefoot, the line joining the third metatarsal, is making an angle and it's medially deviated. So that is, we call it a forefoot adduction. What is the third component? That's the hind foot varus. And for that, we are looking at the foot from behind. And in that, what we are looking is the leg and the heel. This is a long axis of the leg, and this is a long axis of the hind foot. And we can see that it's not a straight line, but it is medially angulated, or it's in varus. So the first is the forefoot pronation or the cavus. The second is forefoot adduction. The third is hindfoot varus. And the fourth is equinus. I'm sure that everyone is aware about equinus, so I'm not going to pay much attention to that or more emphasis on that. Coming to the sequence of correction, I request you to remember this picture of a cave. And that cave basically tells us that C is for cavus, A for adduction, V for varus, and E for equinus. So that's the short term which help us to remember the sequence of correction. So let us understand how we correct the cavus. We already saw this animation that forefoot is pronated in relation with the hindfoot. So in the first or second plaster, we want to correct the cavus. And for that, we basically have to supinate the forefoot. So we have to rotate the foot like this. And when we do that, the first metatarsal and the fifth metatarsal, they are now aligned with the hindfoot. So that is how we correct the cavus. Let us see how we do that on a patient. For that, we apply the pressure from plantar aspect over the first metatarsal and we try to lift it. And that is how we carry out the forefoot into a supination. Now, this is on the patient, like we have applying two finger, one from the index finger is from the medial and the plantar aspect, and the middle finger is purely on plantar side. And that is how we try to correct the cavus. The counter pressure is on the head of the talus, and that is trying to apply the counter pressure. This picture, a patient referred to me by a colleague and saying that the forefoot is not getting corrected. And if you look at this picture, here you can see that instead of forefoot supination, the forefoot is actually everted or pronated. So this is a wrong thing. Just remember that we need to supinate the forefoot. Again, this is a same picture trying to show that if you pronate the forefoot or evert the forefoot, that will not correct the clubfoot deformity. Coming to the second step, that is forefoot adduction and the hindfoot varus. So both this component of the deformity are getting corrected simultaneously in step 2. And to explain this concept, which is I consider as the biggest contribution of Dr. Ponseti in this clubfoot management, is how forefoot adduction correct the varus. So to understand this principle, again, this is a foot model. The red bone is talus. So what he described is to consider the foot as a two-layered model. The first floor or the first layer or the top layer is formed by a talus, and the remaining layer is formed by the rest of the foot bone. So to explain this Ponseti biomechanics, I will show this animation and that will explain it very well, that how with forefoot adduction correction, the hindfoot varus gets corrected. So this is the model which we already described. Here we keep the first thumb of the one hand to apply a counter pressure. And then we apply a force to correct the forefoot adduction. So this is how we correct the forefoot adduction. So now let us see, like once we correct the forefoot, how the hindfoot is getting corrected. To understand this, first of all, let us understand that this first ray as a first metatarsal, then comes the cuneiform, and then comes the navicular. Now, when we abduct this, when we correct this, this navicular also moves laterally, and along with that, the cuboid also moves laterally. Now, cuboid is connected to the anterior end of calcaneum. So when we correct the forefoot adduction, the anterior end of calcaneum also goes laterally. So this red one, the red bone is a talus, this is calcaneum, this is navicular, first metatarsal, fifth metatarsal, and cuboid. So now let's see how it's get corrected. We have applied a counter pressure over the talus, and we are applying the force to correct the forefoot. That's the second layer or the layer which is down. So this is how we are correcting. Again, I will play it because that's very important thing. Now look at, like, as the forefoot goes into abduction, what is happening to the anterior end of calcaneum? Right, so anterior end of calcaneum is also going laterally, and along with that, the hindfoot varus gets corrected. So this is the picture of beginning, and this is at the end of third plaster where the forefoot adduction is completely corrected, and you can see that here talus and calcaneum, they are overlapping, while here they are diverging. So this is how the hindfoot varus is corrected. This is a video which Dr. Ponsetti has played. Sorry, it's not working, but I have a picture also. So this shows that when this is a hindfoot, this is at the beginning where the forefoot is adducted, the hindfoot is in varus. And then when you correct the forefoot adduction, the hindfoot varus gets corrected. Then the question is, we understood this biomechanics, but how to carry out step 2? So for that, this is again a dissection of a foot. We apply the pressure on the lateral surface of the head of the talus, and these are the foot bones. So we apply the counter pressure over here, and then we apply the pressure from the medial side of the foot to correct the forefoot adduction. The question is how to palpate the head of the talus. Whatever may be the size of a child or a weight of a child, lateral malleolus is always palpated, and it's a most prominent bony prominent. So once you palpate the lateral malleolus, go 1 to 1.5 centimeter distally and laterally, and you will palpate a bony prominence. That's a lateral aspect of head of the talus. So we apply one finger or one thumb at this point, and with the other hand, we try to correct the forefoot adduction. This is how we correct it. So the question is how frequently we need to change cast. Usually casts are changed at 5 to 10 days depending on the surgeons and the patient's comfort. Usually the plasters are done under sedation or when child is sleeping. For that, some people, they allow the breastfeeding, while some people like me, they prefer to give albuterol, which is a short-acting sedative, by a nasal spray or oral route. Coming to the third step, that's a correction of the equinus. And for that, in 95 to 98% of the cases, we need to carry out tenotomy. So the question is why we are emphasizing a lot on tenotomy. Most of the time, the parents are reluctant for a small surgery, and why it is required, that I will explain you. So this is a foot model, the lateral side we are seeing. The tendoachilles is short, and when we try to apply or when we try to correct the equinus deformity like this, because the tendoachilles is tight, it will not allow the forefoot to or the ankle to dorsiflex, and a pseudo correction will take place at the talonavicular joint, which we call it midfoot break. So this is a patient where I try to correct the equinus without tenotomy. After few months, after everything was over, I realized that this foot is not normal, and there is some swelling or the prominence of this area. And then I got the X-ray done. And that X-ray shows that this is a long axis of the talus, and this is first metatarsal, and there is a iatrogenic talonavicular or a midfoot break because of not doing a tendoachilles tenotomy. So as I said that in 95 to 98% of the cases, now I prefer to go for tenotomy. How tenotomy helps? When we carry out this, now the posterior tight structure is taken away, and when we apply a dorsiflexion force, the correction takes place at the ankle joint, at the area where it has to be corrected, and not at the talonavicular joint. The technique of tenotomy, the child should be relaxed. It can be done with a 15 number knife or with a needle. The most important point which one should remember, and in exams they will ask, whether you will go from lateral to medial or medial to lateral. We go from medial to lateral side. The reason is because there are important neurovascular structures. I will show you that with the animation. But the important point, the practical point is, as soon as you carry out a tenotomy, the click should be heard or it should be felt. That is the prerequisite for a complete tenotomy. So we are looking at the foot from behind. The leg is horizontal. This one is the heel. So this is what the tendo Achilles. These are the neurovasculars on a medial side. We insert a knife like this, rotate it by 90 degree. So now the cutting edge of the knife is facing the tendo Achilles. We go from medial to lateral and we cut the tendo Achilles. And as soon as it is cut, the complete give way is felt or a small click is also heard as soon as the tenotomy is done. So this is a short video trying to show you. I prefer to do it under inhalation anesthesia, general anesthesia. And this is how we go and then we cut the... And one should get a full dorsiflexion. That is the end of the correction. Now, if it's a difficult tenotomy because of the older child or because of the child having too much of fat in that particular area, in that case, I would suggest you to make a small incision, pass a mosquito underneath the tendo Achilles, and to carry out tenotomy under vision. But important thing is, like, we need to carry out complete tenotomy. So what is the end point? The end point of the Ponseti treatment is a 70 degree of foot abducted. So the vertical line is a long axis of the thigh, and this second short line is the long axis of the foot, and that should make a 70 degree. That is the end point from this view. And from the second view, the foot should be at least dorsiflex to 20 degree. So these are the two endpoints. Please remember that we are not overcorrecting the foot. Any child at this age, at the age of 2 to 3 months, will have this much range of motion. So we are trying to get the full correction. It's not overcorrection. Just to show you how the foot gets corrected, this is the picture of the foot model in the beginning. This is at the end of first plaster, second plaster, third plaster, and then we do a tenotomy and get a 20 degree of dorsiflexion. And these are the all plasters together that shows that how the foot gets corrected. Here you can see that the foot is in plantar flexion and forefoot is adducted. And here we can see that it's a 70 degree abducted and it's 15 to 20 degree of dorsiflexion. Coming to the second phase, that's maintenance phase. Now we need to differentiate between the two, and I will show you what is the difference. But this is where I tell my patients that now it's my duty is over and now I am giving you the responsibility to you, and you have to take care so that foot does not relapse. And for that, this is an important message. Cast is basically for achieving the correction. The braces are for maintaining the correction. Don't expect brace to correct the deformity which is not corrected. We have to correct the deformity fully with plasters, with cast, and then only we should rely on the brace for maintaining the correction so that the relapse does not take place. Usually we go for various types of foot devices, but the foot abduction orthosis is a preferred one, in which the two sides of the shoes, it is connected with the metal bar, and that metal bar helps us to keep the foot into 50 to 70 degree of external rotation. So why do we need foot abduction orthosis? George Mercandeau, the colleague of Ponseti, in 2004 showed in an article that if you don't use brace, the relapse rate is around 80%. You have corrected the deformity, but relapse rate is 80%. However, when we use brace, we can brought it down significantly to 6%. So it's very important that for a long-term good result, it's important to use a brace after we correct the foot with the plasters. We know that the endpoint of the plaster treatment is 70° and we need to maintain the same amount of external rotation or forefoot abduction in this. So this line is a vertical line and the long axis of the shoes, that is again at 70°. If it's a one side deformity, then other side is kept at 50°. A one case example in the end, that this is a child who presented to me at the age of 4 days. You can see the placental clamp also. I started the Ponseti treatment. In 5 plasters, the foot was corrected and then the bracing was given. This is a picture taken at the age of 4 years. You can hardly make out that there is any abnormal. At 6 years, he came first in the running in a class. And the mother was really emotionally overwhelmed that a child who was born with a clubfoot, he is like first in the class in running and he's competing with the normal kids. So this is a picture with that certificate. This is picture at 10 years. You can see that it's very well corrected. There is no evidence of any hindfoot varus, forefoot adduction. And this is a evidence which says that the child can squat normally. So he has a very good dorsiflexion also. So important points which I would like to emphasize is like Ponseti is a gold standard treatment for the clubfoot correction. The sequence of correction is cave. In the second step, forefoot adduction and hindfoot varus are corrected simultaneously. We need to keep counter pressure on the lateral aspect of head of talus. Hindfoot varus corrects with abduction, forefoot abduction. Tenotomy is required in most of the cases. And once we correct the deformity, it has to be maintained with foot abduction orthosis. Otherwise, the good correction which we have achieved with plaster will be lost in next few months. Thank you very much. If you have any question, please free to ask me by email or a WhatsApp. Or even now also you can ask me a question. Thank you.
Did you add something on the surgery we were saying at that time?
Yeah, I have that on surgery. Do you want that?
Yeah. Why not, sir? Why not? That is, why not?
Okay.
There's short surgery steps video also. I think that will be great if you add it, sir.
Yeah.
Please go ahead.
Yeah, please, sir. I just need to open it.
No problem, sir.
Sir, in the meantime, can I ask one question?
Yeah, sure, please.
Yeah, thank you, sir. It was really a master class, if I can call it that. So, the tenotomy that you do, is there any level like 1 centimeter from the insertion, or you just do anyway? I mean, what would you say? Generally, at what level do you do?
Yeah, usually like I try to do it 1 centimeter proximal to the bony piece because that's where the tendoachilles is very well felt. The video is slightly showing a lower down, but usually I prefer to do it slightly above at higher level, 1 centimeter above the tendoachilles.
Yes, sir. Thank you, sir.
So can I ask?
Yeah, please.
Is it me again, sir? So
yeah, please.
The picture that you showed of that boy, that excellent who came first in the running, in that also tendoachilles tenotomy was done, right?
Yes, yeah.
In the picture, subsequent years, we can hardly make that it was done. So it really kind of regenerates, kind of unites. What do you think happens, sir?
Yeah, okay. A very good question. And this was a question which was raised by all colleagues, orthopedic colleagues world over. And Ponseti did a study of doing a sonography after doing a tenotomy at 6 months or so. And they showed that the tendoachilles regenerate completely. So it does not lead to scar formation and it heals so well that on sonography you can't make out where was the tenotomy cut. So, and I have a picture not over here, but like the picture where children are walking on the toes also. So that shows that the plantar flexures has a full strength. They can even hop also. So that's not a big issue. At this age, even up to the age of 1.5, tendoachilles regenerates completely.
Thank you, sir.
Can I ask till what age would you recommend the Ponseti? That's number one. And secondly, you mentioned about the snap while doing the tenotomy.
Yeah.
Is it absolutely
Yeah. So
necessary to
basically,
wear
up to
that?
what
Or,
age? The first question, now if you see
yeah.
the two Indian studies, the one which recently published in Indian Journal of Orthopedics from Wadia Children Hospital and other from Dr. Sahalam, that's from AIM Institute, they have shown a good result of Ponseti technique up to the age of 10 years. They are from the institute where number of plasters does not increase the cost. In my private practice, I usually don't go for Ponseti treatment after the age of 1.5, and I try to reduce the number of plasters by something else. That I will not discuss at this stage. But yes, postgraduates, they can always say that they will go for the Ponseti treatment, even in a late presenter cases up to the age of 6 also.
So there's another question. What is the bracing protocol you use for the?
Okay. Again, there is a lot of differences amongst orthopedic surgeons. Everyone agrees to a point that first 3 months we need to give it for 23 hours. So only we ask to remove it at the time of bathing, and but that's the only thing. So usually they are using it for 23 hours in 24 hours. So that's what for the first 3 months. Then some people give 2 months, 2 hours, 4 hours relaxation. I usually suggest to my parents or to my patient that every month you can reduce it by 1 hour. So usually by 15 months, they will come to 12 hours. After that, I continue for 12 hours in a day till the age of 4 years. So that is what my...
So you can start sharing your screen.
Yeah, sure. Yes, you can see this. So basically coming to the surgeries for the clubfoot, with the Ponseti technique, definitely the percentage of the patients who require surgery has gone down drastically. Currently, at present, the indications for the surgery for the clubfoot are 3. The first is failure of non-operative treatment. As I said that Ponseti technique has a success rate of 95 to 98%. However, there are small number, particularly the non-idiopathic variety, they go for failure, and in that case, we need to go for non-operative treatment. The major reason at this stage is the relapse after the non-operative treatment. Relapse is a very common problem in our country and world over also. So many children, they require surgical treatment for that. And again, a very common in developing countries, the late presentation, the children, those who are in a remote area, they are not taking any treatment, Ponseti treatment at right age, and they present to us at the age of 3 or 4, and in that case we need surgical correction. So these are the 3 indications. The postgraduates, they need to remember the 2 major approaches which we use. The first is a posteromedial approach, and the second is a complete subtalar release. These are the 2 approaches which we usually suggest. So let us understand for this 2 approach. The posteromedial release, in short known as PMR, it's described by Dr. Turco, and this is a J-shaped incision which is curved at medial malleolus. So that's the incision, and this the same incision if you look at from the foot from a medial side. So through this approach, we target the posterior, medial, and plantar structures. So that's about the Turco technique. Now, on the other end, Dr. McKay, Dr. Simons, Dr. Alvin Crawford from USA, they suggested that the another approach is a complete subtalar release. So in that, they suggested 360-degree circumferential release of the subtalar joint and talonavicular joint. So that's another technique or the approach. Now remember that approach is one thing and incisions are different. So for complete subtalar release, there are various incisions. So some people, they use it 2 incisions, in which the medial and the plantar structures are released by an incision, what we saw in the turco. And then on a lateral side, they make a second incision. Some people, they go for a 3 incision technique, and I will show you what are the incisions. So this is a medial incision, which is a slightly curved or serpentile. So when you correct the forefoot adduction, in that case, this serpentile incision will become a straight line, and that will have a less stress on the incision line. So this is first incision. On a posterior side, some people, they put it a straight incision. The other is a serpentile lazy S-shaped incision. So that is, again, it allows a wider exposure. And when the equinus is corrected, it becomes straight. And then the third is the lateral incision, by which we release the lateral aspect of subtalar joint and the calcaneocuboid joint structures. So these are the 3 incisions which we use it for the complete subtalar release. On the other end, Dr. Alvin Crawford from Cincinnati Children's Hospital, they describe an incision which is a transverse incision and which become popular as Cincinnati incision. And this incision starts from the cuneiform, medial cuneiform. It goes horizontally towards medial malleolus, then it curved posteriorly. It goes just below the malleoli, and then on the lateral side, it's continued towards the calcaneocuboid joint. So the advantage of this incision, if it heals well, the scar will be hardly visible. The reason is because this scar line will be inside the shoes or inside the strap of the shoe wear. So if it heals well, it will give a wonderful cosmetic appearance. However, the problem of this scar is like you have to be very gentle while tissue dissection. Otherwise, flap necrosis is one major problem of this incision. Now, one point is like whichever incision we make, that's not important. What we release inside is more important. And for that, we can describe or understand the structures in 2 ways. What are the tendons and the muscles we release, and what are the capsules and the ligaments which we release. So to understand the tendons and the muscles, these are the tendons which we release. The tendoachilles tenotomy, usually we carry out Z lengthening. Tibialis posterior, again we carry out Z lengthening. For extensor hallucis longus and extensor digitorum longus, some people, they do it fractional lengthening, some people do a Z lengthening, or some people, they cut both the tendon and suture one end of the extensor digitorum with the extensor hallucis. So there are various methods of lengthening, but they require lengthening. And abductor hallucis muscle on a medial aspect of the foot, that is also released. So the first 4 are the tendons, the 5th is muscle. What are the structures which are released on medial and plantar aspect? The first is a superficial deltoid ligament. The second is talonavicular capsule, the spring ligament, and the plantar fascia. Now, why these structures has to be released, that I will show you with pictures. So this is a medial aspect of the foot. We are looking at the left side of the foot. This is medial malleolus. This is substanticular italy of the calcaneum, and this is navicular. Now, to release the talonavicular capsule, because the forefoot is adducted, we need to release this talonavicular capsule, and this is the ligament which is connecting the substanticular italy to the navicular. That's a spring ligament. So these are the 2 ligaments which we need to cut. We need to cut the superficial part of the deltoid which is connecting the medial malleolus to calcaneum. The deep part is not cut. We will understand that in a minute. Then the posterior ankle and the subtalar joint are also released. Now, let us understand the 2 structures, the spring ligament. which connects the plantar surface of the calcaneum and the cuneiform and the navicular and the plantar fascia. Now, if you understand that in cavus, both these ligaments, they are short. And if we want to correct this deformity, then we have to cut the spring ligament and the plantar fascia. Coming to the posterior structures, the three structures are the posterior ankle capsule, posterior capsule of the subtalar joint, and a calcaneofibular ligament. Why they required a release that we will see with this picture. This is a foot having a forefoot adduction, hindfoot varus, and equinus. You can see that this calcaneum is very near to the tibia, and this ankle and the subtalar joint capsule is short. Now, if you see this model in which the correction is achieved, you can see that the calcaneum has gone down, and for that, these two capsules, the subtalar and the ankle capsules, has to be released. The another important thing is a ligament called calcaneofibular ligament, which is shown by this string, which is connecting the tip of the fibula, that's lateral malleolus, to the calcaneum. And here you can see that as the calcaneum goes down, the ligament has to get stretched. And in surgery, we have to cut that ligament so that hindfoot varus gets corrected completely. The important thing is that don't release talocalcaneal introosseous ligament. The introosseous ligament, they are connecting the talus and calcaneum. We have released the subtalar joint 360 degree, but in the center there is talocalcaneal introosseous ligament. They are not cut because over that, on that axis, the subtalar joint will correct it. If you cut that, then there is a possibility that in addition with the rotational correction, translation will also take place. And the other structure which is not released is dip deltoid ligament. Examiners ask this question that which are the structures which are not released. So we need to answer that talocalcaneal introosseous ligament and a dip deltoid ligament. For that, to understand that the deltoid has a two part, the superficial part which connects from the medial malleolus to sustenticuli tali, and the deep part which connects with the talus. So in surgery, we release the superficial part of the deltoid, but we don't cut the deep part of the deltoid. Then in a late presenter cases, once the child starts walking, the lateral column becomes long, and for that we need to shorten the lateral column along with the soft tissue release. And for that there are various procedures. The Lichbrow procedure is excision of the anterior end of calcaneum. So once we connect, remove this, resect this area, this surface, bone surface will form a fibrocartilage, and pseudo joint will be formed between cuboid and this fibrocartilage. But that will shorten the lateral column and will allow the foot to correct completely. In Goldner procedure, we take out a triangular wedge from cuboid. In enucleation of cuboid or decancellation of cuboid, we take out the cancellous bone from cuboid, and then we correct the deformity. We apply the force, and that will crumple the cuboid. And lastly, in Evans procedure, both articular surface from calcaneum, anterior calcaneum, and cuboid, they are removed, and they are fixed with a staple or a K-wire with the idea that ultimately there will be a calcaneo-cuboid fusion. This procedure is carried out in a children who come to us after the age of 4. Evans procedure should not be carried out in a child who is less than 4. The advantage of surgery is that it gives a quick correction, and patient does not have to come to us for 7 or 8 plasters. It gives us quick correction. This is what the child who presented to me at the age of 3 years. And you can see that it's very well corrected with a hemi-Cincinnati type of approach. We use 2 incision techniques. So this is for the medial and plantar structure, and there is another incision on a lateral side. There are few disadvantages of surgical treatment, that skin healing is a problem. Particularly, the reason is because when we correct, the medial and the posterior structures have a tension on the skin, and that will not allow the skin to heal properly. we are cutting the capsule and then we are giving plaster after surgery. So stiffness is a major problem of operated cases. This is how there is a big difference between the patients who are operated and the Ponseti treatment. The Ponseti treatment patients have a good flexible foot, while those who are operated, they have a well-corrected foot, but it's stiff. The complications, yes, they are there. The first, as we discussed, is a skin necrosis. Undercorrection and overcorrection in almost 20 to 30% of the cases, we have this problem. Infection rarely because it's a 1.5 hour surgery, and in some patients when there is a skin problem, the infection also take place. And avascular necrosis of talus, because we are releasing the subtalar joint by 360-degree, and in that case sometimes we may jeopardize the blood supply to talus. So this is a picture which showing overcorrection. Here we have achieved correction, but you can see that hindfoot is in extreme valgus. And this patient required a second surgery for this overcorrected foot. This is a same patient where you can see that instead of having a good correction, the talonavicular joint is dorsally subluxated. So this is talus and this is navicular, and navicular is dorsally subluxated. Here also you can see that the first metatarsal and the phalanx, there is a subluxation. So there is a dorsal bunion also. I would just like to end my talk with a warning to the postgraduate student that please don't consider surgery as a cakewalk. This is a picture of a child who presented to me after undergoing 2 surgical treatments. You can see that the deformity is very severe with a 2 big incision, and you can see that this incision, the third picture shows that it's not healed well. So surgery gives quick correction, but the complications are also very serious. So I would like to end my talk with a take-home message that it's a quick, rewarding procedure, gives quick correction. Stiffness is a problem of surgically treated clubfoot. This treatment has a higher complication and serious complication. So if you are not well versed with this, please take help of your colleagues who is having a good experience in this surgery. Otherwise, you will ruin a foot of a child for lifetime. So with that, I would like to stop my presentation. Thank you.
Thank you, Dr. Dhiren. It was really a wonderful talk, and we could really understand much better the CTV. Final comments from Dr. Sureshwar Pandey on this talk, and then I will request Dr. Ajoy to ask people if they have any questions so the panel can answer. So final comments about this talk on Dr. Dhiren.
I must congratulate the speaker to summarize the treatment of clubfoot, which remains a problem, which is remaining a problem, and which will remain a problem. My teacher, the lamented and emeritus Professor Bhim Upadhyaya, perhaps I hardly seen all over the world a person who has done, other than Ponseti, that has done more a clubfoot. And he has rightly said one word, that in whole my lifetime, I have not corrected a single clubfoot. And that he tells that you say the patient to come for his lifetime, you will find that in the end he has some problem. So my experience has been also little that I have not corrected a single clubfoot to the fullest extent. No doubt, Ponseti's technique has prevailed a lot. But you see the recent publications, the complications, and the all plus points of Ponseti are being commented in several cases. I am not saying most. It certainly is a very good procedure, but when Ponseti evolved this treatment to get the good result, where the children were brought at quite early age, but once the clubfoot at our places they come, they have certainly some problem and something have to add. I wish whatever the learned speaker has talked about the Turco's procedure. Turco himself has commented on his procedure. Surgery is not to be hated. I repeat the word. Surgery not to be hated. It had to be done in the proper way. The incision has been modified. Cincinnati approach itself being commented at its place of origin. Turco himself has commented, we have met Turco at many places, has commented that a single incision for that from medial side or posterior medial side has certain disadvantages. I'm not saying that double incision or triple incision, but double incision properly done has certain merits, and it is not to be afraid of. If he is going to produce a stiffness, it is only because of the rough surgery, improper incision, improper dissection. It is not always a stiffness. And if anything which is coming as infection, adhesion has to be there, a stiffness has to be there. Complications of surgery are not that highlighted, and in a proper case, surgery must be done. Surgery must be tried. And if the speaker has very well said that it can be tried even at the age of 10 years. I remember the words of Watson Jones. There is no fracture in the world which can't be treated with not plaster. All can be treated. Similarly, there is no clubfoot which can be corrected. And many clubfoot, if you won't correct, they will run and play. This does not mean that you should not correct the clubfoot. It must do at proper age. And if the child comes at the age of 4 to 6 years, 7 years for the clubfoot correction, what will be the relation of the all bones? What will be the size of the bone which has developed in a deformed way? You have to consider. And in that case, proper surgery must be done. You can try concerted technique, certainly, but certainly there will be not that correction which that patient or others will expect. I must say the clubfoot remains to be a problem, and it is going to be there because we do not know its cause. So all our young colleagues, young surgeons should concentrate on managing clubfoot as early as possible, preferably by non-operative technique. But once surgery indicated, say by the age of 3 or after that, proper surgery must be done. Thank you very much for giving me the chance. I really enjoyed and pray that I should live longer to learn. My copy is full for taking the notes, which I certainly say with the pen, and I must attend it. I must congratulate, must thank you.
Thank you very much, sir. Thank you very much. And Dr. Joy, you can invite questions, and the faculty is there. If there's any question, you think that we are left with any question, or otherwise you
No,
can
none of
thank
the questions I
everyone
was.
on my behalf, the whole team, the company, the delegates, and the company who have done it. So you can take the honors of doing that.